You'll recall that many moons ago, a Secretary of State asked Dame Christine Beazley, the previous Chief Nursing Officer for England, to half MRSA and then to go on to do the same for C. difficile. Well, our current Secretary of State, Jeremy Hunt, asked us, as a collective, us to do the same and half gram-negative bacteremias by 2021. We've taken the end of March 2017 as our baseline and to the very end of March 21 as our ambition to half gram-negative bacteremias. All really important stuff, and you'll know this more than me as frontline infection prevention teams, that 80% of these are a community onset. We're concentrating on those three first, the E. coli, Klebsiella, and Pseudomonas, because of the numbers keep going up, particularly that of E. coli. The numbers have been going up now for many, many years, and I believe that you, over the last couple of years in particular, are taking huge action to start to bring those down. Now, that's just a reminder that these are around patients. These are around people that have these infections. The numbers of in MRSA, 1.4 in every 100,000, going up to 73 in every 100,000 for E. coli. Huge numbers of people that are being affected by these bacteremias. You'll know this, it's regular information that you guys see. I wanted just to raise just 3 points on this. If we do nothing else, if we target nothing else in this, it's about the elderly, that middle risk of males more than female even, but the elderly, most of it, of course, is in community onset, and, of course, with the UTIs. So if we do nothing else, we concentrate on those three areas, we'll make some huge difference for what we need to be doing. So the programme objectives, it was, yes, to learn from each other. There's some great examples. We've heard some examples this morning with sepsis, prescribing, AMR, news, all across England and beyond. So it's how do we gain the benefits, the excellence of practice that you're currently doing and spreading that. So there is a resource package that has been developed. We asked also to extend the mandatory surveillance for Klebsiella and Pseudomonas as well as E. coli, and that has been done. Over 1,000 of you across England have joined us in our 5 PIN events, which have been fantastic, and we've been working across all the system leaders to do this. So what has been achieved, I've covered part of that right now. One of the things on that third bullet point, as we've talked about, is that the risk factor data is not mandated. Some of you are doing it, and those people that are doing it are starting to get some real insights about what is the cause factors. How do we absolutely go back to prevention? There is a debate going on about whether we mandate doing the risk factor work. That is going to be a big burden for you to do, and that's why we're having some considerations. Your views on that would be helpful. Whether we mandate it just to do for 1 quarter to give us some information, we don't know, but it's one of the things that I could do with your advice on, either via Twitter or via email, or come and just talk to me later. We've been out and about around the country. We've also, with the help of Susan Hopkins in PHE and her colleagues, with Mark Wilcox, who's also supporting us, started to define, or we have defined, the healthcare-associated gram-negative in terms of the definition for it. These are some of the events, and the reason I wanted to show you this was that it's been co-designed by you. It's not us in a little black room with our hoods on devising this. It's actually you guys helping us work this through. So if there's more improvements, any corrections we need to make in the improvement resources that we've got, tell us, and we will look at it. Now, this is what we wanted you to really concentrate on, this healthcare associated. It's A and B that we want to look at. There's 32,038 cases is our estimated number of gram-negatives. We want to half that. So it is the hospital and the community onset, but it is only the healthcare associated that we want to tackle, because we think that we're able to do that. Some of the work that has been done as well with our fabulous economic teams in the old monitor part of NHS Improvement has done the financial case for action. This is something that if I was in your position, I'd be using. You can put in your figures, your activity numbers, and you can come out with the pound signs that are potentially for savings. It's really important a tool for you to be able to convince some of your executive colleagues, perhaps your director of finance colleagues in particular. But the most important part of this is about patience. It's what we can do collectively across all of our professional disciplines to reduce the amount of harm and excess deaths for patients. So this is a very simple chart for me, which is if we do nothing, these figures, these numbers of patients affected by E. coli are going to continue. This is a chart then that shows for us that we're starting to make some inroads collectively. Until April 2017, we saw a 6 to 8%. I know some of our colleagues this morning said 10%. One of the things we absolutely need to get is one state of the truth, one group of figures that we all align to. But at the moment, it's anywhere between 6, 8 and 10%. If we had done nothing, it would have carried on increasing. It's good to see that we've started to see for the very first time for us to be reducing. The level of increase is reducing, but also we've reduced below last year's number as well. But we're way below, we're way above, we're way further away than where we need to be for our trajectory for 2018 and onwards. So we've got much more to do, but it is more complex. I remember being a chief executive of King's Lynn Hospital in Norfolk when Dame Christine came out and said we're going to half MRSA. I thought that was possible. The numbers were something that as a chief executive I thought, yes, perhaps we could do. When I was at Mid-Essex chief executive a couple of years later, and she came out and said, we're going to do the same for C. difficile, I thought she'd lost her marbles. Genuinely, I thought she'd lost it. I didn't think it was achievable. When we've asked people in the room at our PIN events, do you think it's achievable to get to halving gram-negative bacteremia by 2021? People have said yes and no. But when you ask people whether we should work to halving it, the absolute 110% of people have said yes. And I believe that is genuine commitment from people in this room and beyond. So we're on a journey. It's not going as well as what we want it to do. We need to do more, but we are seeing some starts to signs to do this. CCGs, and I'm delighted to see that the new medical director for NHS England, Professor Steve Powers, is really getting behind this programme and has agreed to be the national NHS England lead, joining me in this work. And I'm really pleased that we're able to deliver together through CCGs, through providers across England, something I hope that we'll get to where we need to for patients. One of the things that's really important as well is that we've been working with other ALB colleagues like the CQC. I'm delighted that the CQC have now agreed with social care and Andrea and in Ted with the hospital care that they're going to be asking on their well-led inspections about your action plans for gram-negatives. They're going to be asking to meet your Executive Director for Infection Prevention and Control. I'm delighted that the CQC are going to be asking as part of their inspection regime about gram-negatives. I believe, therefore, we'll see boards really getting to grips with this in the same way that they did with MRSA and C. difficile. Perhaps we've lost a bit of ground over the last couple of years as MRSA and C. difficile have been such a success, they've been so well under control, that perhaps boards have just been looking at MRSA and C. difficile and not some of the up-and-coming infections like E. coli. We're asking you, we're asking boards, we're asking the CQC to make sure organisations, whether that's CCG or indeed acute and community and mental health trust, so what plans have a board seen? Have boards seen a paper on MRSA, C. difficile and gram-negatives, so making sure that all infections are being reviewed by boards. I think I've covered part of that, but the last bullet point on there is something I really just want to emphasise. We have heard from the PIN events and from people like yourselves that we want to make sure, we want to support those people who want to aspire to be a DIPSI and an executive director for an executive director for infection prevention control, or those people new into post. So in April this year, we will be launching our Aspiring Director Programme, our Executive Director Programme. It isn't a programme that's there to teach you how to do microbiology or infection prevention and control. You know that anyway. It's about how we support you as leaders to work across systems, to work and influence boards, how you develop as an executive director of IPC. I think that's going to be really important to support you over those periods and your challenges. The other thing I wanted to bring to your attention on this one is that the last point is around our UTI breakthrough collaboratives. We've done a lot of work in NHS improvements. One of the things we've worked on is about our 3 areas of learning for big improvements and sustained improvements have been around the leadership, and that's why we're going to invest in the leadership course I've just spoken about, engagement, and that's why we're doing the PIN events. That's why we come to this type of event and engage through this as well as social media and the like. And the other one is around quality improvement methodology. So we're investing a lot in the collaboratives, and we're going to focus on UTIs, mainly because that's one of the areas that is the main traction for achieving this programme. So in April, we're going to launch a series of masterclasses. In May, a collaborative programme for 30 organisations. If you want to be part of that, then just come and talk to us. You may be one of the lucky 30. You may not, but we'll work to see the level of interest as well, to see whether we need to put on a second cohort. So the challenges are more than what Emma was saying, C. difficile. It's very much across the whole of the spectrum of care. But it's one that I believe if collectively we provide the leadership, then we will get there. I'm delighted with how this programme is working so closely with Celia and Sepsis and colleagues and News. It's really important that we do that to be able to have a coordinated method and a coordinated narrative. So these are my contact details, and Linda and Gavin, but you'll know also that Mark and Susan are around to support. Please engage with us. Please tell us where we're getting it right. Please tell us where we're, more importantly, what we need to do more to support you. We're there to do that. You can get that's my email address, but you'll get me on Twitter as well. So please engage with us so that we can make an improvement for our patients and our public that we serve. Thank you very much, ladies and gentlemen. Have a great afternoon.